Good morning, everyone. Our today's topic is we'll be discussing about alveolar bone. What is the role of alveolar bone in periodontium? It plays a very important role because it forms the basis or the support of the teeth. So you can say that it's a portion of maxilla and mandible that forms and support the tooth socket. Usually the alveolar bone forms when the tooth erupts to provide push attachment to the forming periodontal ligament, and usually it gradually disappears after the tooth is lost. Going back to a little bit of anatomy, what you have learned in first year. So this image, you can see the images of a mandible, and you can obviously see the body of the mandible, rims of the mandible, coronoid process, condylar process, and in the green color, what they're told is that is your alveolar bone, and also you can see your mental foramen. So let's see which are the parts of the alveolar bone. So we have a inner and outer cortical plate. We have the bone lining the socket. Then there is an interior portion of the cancellous bone. So these are the three main parts of alveolar bone. We have a cortical plate which has got an inner and outer surface. Then we have the bone lining the socket, and we have the cancellous bone, which is the interior portion of the or in between the cortical plates. The cortical plates is usually made of compact bone. Compact bone is usually very tough and very hard, uh, in which there is a lamellae which is arranged circumferentially around the blood vessel, forming a Periosteum system. So these cortical plates usually consist of compact bone, made of compact bone, which is usually hard. And in this cortical plate, you can see Hawaiian system. That is, Hawaiian system is something which carries the blood vessels. They are the internal mechanism that bring a vascular supply to the bone. So Hawaiian systems are there within the compact bone, which brings your blood vessels or blood supply to the bones. The cortical plates, that is your outer and inner cortical plates, and the bone lining the socket meets at the alveolar crest, usually 2 mm below the cemento-enamel junction. Bone lining the socket is also made of compact bone, which is usually known in different names because of the different functions. So it's known as bundle bone, it's also known as cribriform plate, it's known as alveolar bone proper, and it's also known as lamina dura. Now, why there are different names for the same bone? It's all because of different functions. So it is called as bundle bone because the bundle of the Sharpie fibers from the periodontal ligament are embedded in it. It is also called as cribriform plate because it is perforated. This particular compact bone is perforated by numerous vascular channels or blood vessels. It's also called as alveolar bone proper because it provides a direct bony support for the teeth, and it's also called as lamina dura, and usually you can see in the radiograph there is a widening of the periodontal ligament. So when you see that, you call it as lamina dura. This particular radiograph, you can appreciate the lamina dura. You can see the right side diagram. On the right side there is a white line on an extracted socket. That is nothing but the inner surface of the bone, or the bone which is around the tooth. So that is shown as lamina dura. White in radiographically, you can see it is in a whitish color. Usually we see cancellous bone in between the cortical plates. So as I told earlier, cortical plates are usually quite hard. It's made of compact bone, but here cancellous bone is comparatively less thicker compared to your compact bone because it is usually punctured with a lot of trabecula. It is quite porous. So the strength is much lesser compared to your compact bone. So it usually consists of a narrow, irregular bony trabeculae, which by branching and uniting forms a network of spaces between the trabeculae. And the proportions of the compact to the cancellous bone in a different region varies. For example, in the lower incisors, which consist of a thin outer cortical plates and the bone lining the socket with no intervening cancellous bone. So different areas in the oral cavity, we may not have a cancellous bone at all, like for example, the lower anterior. So, but usually, most of the areas it has got a cancellous bones is usually which is between the inner and the outer cortical plates. Coming to the composition of alveolar bone, it has got a cellular component and it has got an extracellular matrix as well. So the cells in the alveolar bone usually are osteoblast, osteoclast, and osteocytes. And the extracellular matrix usually we have 65% inorganic and 35% of organic matter. So cellular components we have osteoblast, osteoclast, and osteocytes. First we will discuss about osteoblast. So as the name implies, osteoblast is something which can produce the alveolar bone. So usually they are cuboidal cells with a well-developed rough endoplasmic reticulum, large Golgi apparatus, and secretory cells vessels. The most important function of your osteoblast is it synthesizes the bone matrix. Bone matrix is otherwise known as osteoid and it regulates its mineralization. So it produces the bone and it mineralizes the bone also. So it has got a very important function. Now each osteoblast carries out a cycle of matrix synthesis after which it is either buried or as an osteocyte or remains on the surface of the resting or inactive osteoblast. So after their life cycle, what happens is it is either buried as an osteocyte, or it remains on the surface as a resting or inactive osteoblast. The next type of cells what we have is osteoclast. So osteoclasts are usually large multinucleated giant cells. It originates from a hematopoietic tissue and formed by the fusion of mononuclear cells, generally found in a bay-like depression in the bone called as Howship's lacunae. The part of the cell which is in contact with the bone secretes hydrolytic enzymes, which helps in osteoclastic activity. So we mentioned about osteoblasts which can deposit bone. The same way you need osteoclasts also to lies the bone or to resorb the bone, because once the bone becomes old it has to get resorbed and the new osteoblast has to come. So this activity has to go on. There should be a balance between osteoblastic activity as well as osteoclastic activity. Third type of cell is osteocytes. So as we described earlier, osteocytes, once the osteoblast finishes osteoblastic activity, it rests and we call it as osteocytes. Usually it will be inactive. So it is usually seen in lacunae within the calcified matrix during the fetal growth and alveolar bone formation by intramembranous ossification. Usually they extend the process into canaliculae that radiate from lacunae. The main function of this canaliculae is to bring oxygen and nutrients to the osteocytes through blood and remove the metabolic waste. So we have two types of, we have inorganic extracellular matrix as well as organic extracellular matrix. Inorganic 65% and organic is 35%. 35%. Now, inorganic we have minerals such as calcium, phosphate, and along with hydroxyl carbonate, citrate, and trace elements of sodium, magnesium, and fluorine. In organic matrix, 90% of the organic matrix we have type 1 collagen, and there are small amounts of osteocalcin, osteonectin, BMPs, that is bone morphogenetic proteins, proteoglycans, and glycoproteins. Fenestration and dehiscence. These are the two terminologies you can see in the alveolar bone chapter. And what is fenestration and what is dehiscence? So fenestrations are isolated areas in which the root surface is covered only by periosteum and the gingiva with the intact marginal bone. I'll explain to you when there is a diagram. Uh, when the marginal bone also is denuded, we call it as dehiscence. So in a way, both are similar. We have fenestration and we have dehiscence. Dehiscence. Fenestration, there is a loss of bone, but intact marginal bone is there. And dehiscence, we lose marginal bone as well. Usually you see this. These are the some defects. They see more often in the facial bone and in the anterior teeth. Usually seen more in the anterior teeth. Now you may understand it slightly better. So there are two labelings there. One is fenestration and one is dehiscence. Fenestration, you see that the particular tooth which is labeled as fenestration, you can see the exposed root surface. Root. Partially the root is exposed, but there is no bone there. We can see the root directly from there. But in that particular tooth, you can see there is a small amount of marginal bone covering in the cervical area. So it is not completely denuded. There is an isolated area of loss of bone where the root is exposed. So you call it as fenestration. Now the adjacent tooth, you can see that tooth where it is labeled as dehiscence. You can see that there is a complete loss of bone. You can see that there is no marginal bone. So whatever the root is available, that is completely exposed. No marginal bone there. So the difference between fenestration and dehiscence is presence or absence of marginal bone. Which are the predisposing factors for this fenestration and dehiscence? One is root prominent. Those who are having prominent roots or the bulging roots with thin bone all over the surface. So those are the very good candidates for fenestration and dehiscence. And tooth in malposition, those tooth in malposition, the teeth in labial version with thin bony plate. Some people, their teeth is naturally more labially placed with thin bony plates. So usually these are the candidates which is more likely to have fenestration and dehiscence. This is our kind of what you call as bony defects. Now the problem with this fenestration and dehiscence is usually when such patients need a periodontal surgery, it may affect the outcome or of surgical treatment. So periosteum and endosteum, we know that the tissue covering the outer surface of the bone is called as periosteum. The tissue lining the internal bone cavity, what we call as endosteum. The inner layer of periosteum usually consists of cells which has the potential to differentiate into osteoblasts, and the outer fibrous layer contains blood vessels and nerves. Uh, Osseous topography of the bone differs from individual to individual. The anatomy is different for every individual. Factors affect the height and the thickness of the facial and the lingual bony plates are alignment of the teeth, angulation of the root to the bone, and occlusal forces. When the teeth is in labial version or what you call as more labially placed tooth, the margin of the bone is located more apically and is thin as a knife edge compared to a teeth with a proper alignment. And when you do likewise, vice versa, when your teeth is in a lingual version, that is more lingually placed, usually your facial or your buccal bony plate is much thicker than the normal, and margin is usually blunt, round, and horizontal. So blood supply to the alveolar bone usually it is supplied by alveolar arteries, and they send branches through periodontal ligament and enter the marrow spaces through the perforations of cribriform plate. Interdental septum, which consists of a cancellous bone bordered by the socket wall cribriform plates of approximating teeth and the facial and lingual cortical plates. If the interdental space is narrow, the septum may consist only of only the cribriform plate. Remodeling of cellular bone, usually we know that we have bone formation, usually what we call as osteoblastic activity, and we have bone resorption, what we call as osteoclastic activity, or it is facilitated by osteoclasts. And this osteoblastic and osteoclastic activity, usually which is they are influenced by local and systemic factors. Local influences are the functional requirement of the tooth and the age-related changes in the bone cell. So there are variations. The different age you have different type of alveolar bone formation, and the systemic influences usually are hormonal, which is involves parathyroid hormone, calcitonin, or your the vitamin D3 deficiency usually affects in your alveolar bone formation. And the remodeling of the alveolar bone affects usually in its height, contour, and density. So the balance between the formation and resorption is very important to maintain a healthy alveolar bone. So that's it. That's it from me today, and thank you very much.